I'm presenting a case of a 54-year-old patient who came to our center with a chief complaint of gradual but rather rapid diminution of vision in the left eye over the last year. He stated his contact lens prescription changed rapidly within that period. He has been told he had a cataract in the left eye and he came to discuss the surgical options. The patient had glasses that were a couple years old, with a prescription of approximately -2 in the right eye and -4.5 in the left eye. However, on exam day and with retinoscopy, the refraction of the left eye was -8 with a high degree of astigmatism, and the measurements could not really be obtained with the autorefractometer in the left eye. On slit lamp exam, there was a small nuclear cataract in the right eye and a cataract of a similar nuclear density in the left eye that certainly does not really explain the large myopic shift. But there was also inferior sectoral cortical changes and inferior lens, and iris were possibly slightly displaced anteriorly. And the anterior chamber depth was uneven and certainly shallower in the left compared with the right eye. Fundus examination was normal on a first glance, but scleral depression revealed an inferior uveal mass involving the pars plana and pars plicata. On gonioscopy, however, there did not appear to be involvement of the trabecular meshwork. We did a diagnostic B scan, which revealed a uveal mass of low to intermediate internal reflectivity, and we referred the patient to the ocular oncology service at Bascom Palmer Eye Institute, where the patient was diagnosed with a ciliary body melanoma and treated with iodine 125 plaque radiotherapy. After the tumor started regressing, the patient was sent back to me for management of the cataract. The anterior chamber has now become deeper with a more even depth, and the mass was certainly regressing. We can see the anterior chamber depth is more or less equivalent in both eyes in this IO calculation printout. The decision was made to proceed with cataract surgery with intraoperative aberrometry using the Aura device to confirm the IOL power intraoperatively. I start by making a paracentesis incision, and I inject some lidocaine, some trypan blue. I wash it off with balanced salt solution. Then I inject dispersive viscoelastic to fill the AC. I then proceed to making a clear corneal temporal incision, and I initiate my capsulorhexis with a cystotome. I did not really feel there was any inferior zonular weakness while creating the capsulorhexis. I then proceed to completing the capsulorhexis with a uteratoforceps of about 5 to 5.5 millimeters in diameter. It was slightly inferiorly decentered, but it was okay. I then do a hydrodissection, and I really wanted to prolapse the nucleus out of the capsular bag just to be sure that I don't really exert any undue stress on the zonules. Phaco probe inside the eye, and then the chopper from the side port, and I mainly use vacuum to kind of like remove the lens. Really, there was very minimal, if any, ultrasound power that was used. The chopper was used mainly to support the nucleus while the phaco is aspirating it, the phaco probe, and protecting the posterior capsule at the same time. And then I proceed to cortical removal with the IA tip. I try to keep the inferior cortex until the very end to avoid injuring the zonules while there is any cortex still remaining. I then polish the posterior capsule as well as the undersurface of the anterior capsule, the rhexis edge. Make sure that I get as many of these small opacities as I can. I then inject some viscoelastic to fill the bag before I inject the lens. I do the aberrometry, but there is no screen layover, so we'll skip that part. But here comes the lens. I injected 3-piece lens, and this is a silicone lens, and I know it pretty well. It's very slippery, and the moment you start doing the IA, it bounces around, but this was not the case. So I was suspecting that one of the haptics is cut up, and yeah, here was trying to find out if there was anything, trying to mechanically bring the pupil down, but trying to rotate the lens, it wouldn't really rotate, so the haptic must have been really stuck somewhere. So I injected more viscoelastic, and then with a Kublin hook I rotate the lens. Yes, there was a haptic in the sulcus. Now the entire lens is in the bag, both haptics are in the bag, and I remove viscoelastic from behind as well as anterior to the lens, and I try to mechanically bring the pupil diameter down, and I hydrate the incision and make sure that the IOP is good, no leakage, looks good to me. The patient did achieve a very good visual outcome the very first day with almost 20/20 vision. And the recommended MRI surveillance of the liver is like every 3 to 4 months, chest x-ray every year, and liver ultrasound every 6 months. Thank you so much for watching.